Hi everyone. I work at a busy poison center, and many of the people who call us for help are parents and grandparents of children who have found medicine bottles or loose pills and have possibly ingested some. Although most pediatric poisonings are very common, and fortunately most of them result in good outcomes, with fatalities being rare, a lot of people, especially even some healthcare providers, aren't really that familiar with what toxic doses are of a lot of the medications. And most people will assume that one dose of anything won't be toxic to anyone, but that's not necessarily true, especially when we think about small children. Poison centers get calls frequently about toddlers getting into substances, usually medicines, that can be harmful if they swallow even just one. So pharmacists and other healthcare providers really should be aware of which drugs are considered low-dose, high-risk drugs in toddlers. So let's start by looking at pediatric poisonings in general and some statistics about pediatric poisonings. Each year there are about 1 million poisonings that are reported to U.S. poison centers that involve children less than 6 years of age, and about 500,000 of those involve medicine. So that's one call of every minute of every day to a poison center that involves a small child that's gotten into a medicine. The majority of those are in kids younger than 3 years of age. Fortunately, about 90% or more than 90% of poisonings in small children reported to poison centers have good outcomes, and they don't require any medical treatment because the product that was ingested had minimal or no toxicity, or because a subtoxic amount of a substance was swallowed. But recently a study came out that was done by Safe Kids Worldwide, and they looked at data sources such as the Centers for Disease Control and Prevention and the Consumer Product Safety Commission. And the results of their study showed that in 2011, more than 67,000 children less than 5 were treated in an emergency room or emergency department for medicine poisoning, and most of those were 1 to 2 years of age. So that's one child every 8 minutes. The numbers have increased. The number of emergency department visits in kids less than 5 increased 30% since 2002. And more than 12,000 of these children required admission to the hospital. Every day, 185 children go to the emergency department for unintentional ingestions and dosing errors, and 35 will be admitted. Hospitalizations have increased. They've increased 53% since 2002. So the trend is for possibly more serious poisonings that are being reported to poison centers. As I mentioned, the peak age for poisonings in children is between the ages of 1 and 3, and most of those are unintentional and reflect the toddler's developmental behaviors. Children are very curious. They explore. They put things in their mouths as part of the learning process. Their capabilities can change very rapidly from crawling to walking and then to climbing, and they often have abilities to grasp and open containers. They can be attracted to colorful products and also products that look very similar to edible items like food and drink. Also, small kids will imitate adults. We know that they imitate you doing things around the house, vacuuming, cleaning at times, but they also like to imitate adults taking medicine or using other household products. They also don't know what's harmful to them. They don't necessarily know what's right and from wrong as far as access or getting into or swallowing these products. They don't realize that it could hurt them. There are also physiological differences. Children are not just little adults. They have a smaller mass, and so the overall exposure of a particular dose is greater in a child than an adult. So, for example, 50 milligrams is less than 1 milligram per kilogram for an adult, but 50 milligrams of that same drug is about 5 milligrams per kilogram for a child that may weigh about 10 kilograms. A child also metabolizes drugs differently, and the distribution of a drug might differ, increasing the availability of drugs to act on receptors or organ systems. Safe Kids Worldwide recently reported, that same report that recently came out, they found that 86% of emergency room visits for poisonings by pharmaceuticals in young children were due to the child getting into an adult medicine. Most of those medicines belong to grandparents. 38% belong to grandparents, and then 31% belong to the child's mother. So overall, 7 out of every 10 poisonings that involved a medicine, the medicine actually belonged to a grandparent or the child's mother. This shows that children are exposed to medicines that belong to a trusted caretaker and that they can pose a serious risk that requires emergency room treatment. Medicines belonging to a sibling, a father, an aunt, and an uncle are also the cause of pediatric poisonings. Although it's not really included in this graph, it's important to consider that a child's own medicine is also a cause for concern, especially when parents and caretakers leave the medicine in an accessible place for convenience, so they'll remember to give it to the child. We can also look at the location of where kids get into medicines, and that can help us learn how to prevent poisonings in the future. This same study done by Safe Kids Worldwide showed that 67% of the medicine poisonings were left within a child's reach. So they were left on a table, they were left on a counter, or in a purse that was accessible to the child. 27% of those left the medicine on the floor. Maybe they dropped it on the floor, or it fell under a sofa cushion, or someplace else where it was left accidentally. So it's important to realize that a lot of these kids are getting into medications that are dropped on the floor or easily accessible to them where they've been left out accidentally. 20% of those poisonings, the medicine was found in a purse or a bag or a wallet, and in 20% it was on a counter or on a table or a nightstand. 15% of the medicine poisonings, the medicine was actually obtained from a pill box or daily pill container or a bag of pills. In only 6% of the cases, the medicine was actually put away in a cabinet or drawer, and the child had access to it by opening that cabinet or drawer. So these statistics show that putting medicine up and away and out of sight is probably a good way to prevent poisonings. And remember also that children often get into medicines that belong to a grandparent, so it's important to make sure that these items are not accessible to kids, not only in their own home, but also in a relative's home. So let's look at the medicines that are involved in pediatric poisonings as reported to poison centers. This is a list of the most common medications that are reported to poison centers in pediatric poisonings. The top drug is ibuprofen, which was involved in 9% of poisonings, and that would be children's as well as adult strength ibuprofen. Diaper rash, like Decidin, would be another product that kids get into often. Children's acetaminophen, children's vitamins that don't have iron or fluoride would be the next most common type of medication. Antihistamines that exclude cough and cold medicines, so that might be something for an allergy. Antibiotics, calcium supplements, diphenhydramine alone, so Benadryl or maybe something like Pediacare Children's Allergy, laxatives, and also homeopathic agents. Now, none of these are likely to produce serious toxicity. Maybe diphenhydramine, maybe the antihistamines, but most of them are not going to produce serious toxicity in small amounts. But there's been a trend that we're looking at. The number of pediatric overdoses due to opioids and cardiovascular drugs has increased since 2008. Now, there are drugs that can be highly toxic, so we're really concerned that we could see an increase in serious poisonings and deaths because of greater access to these types of medications. Pediatric fatalities in children less than 5 are rare. In 2011, there were only 25 fatalities that were reported to poison centers. 48% of the deaths, pretty much from year to year, that are reported to poison centers in small children are due to medications. 64% of deaths, and when looking at other data sets, 64% of deaths were due to medications in 2010 compared to 40% in 2011. So the proportion of fatalities due to medicines is increasing. Also, when looking at poison center data, we can look at what are the common drug classes that are causing pediatric fatalities. And at the top of the list are the opioids, primarily methadone and fentanyl, but other opioids as well. Many of them are very potent opioids, prescription analgesics. Acetaminophen is also in that list. Stimulants and street drugs, maybe something like methamphetamine, tricyclic antidepressants, bupropion, aspirin and salicylates, and that would also include methyl salicylate, which I'll talk a little bit about later, quetiapine, calcium channel blockers, and cough and cold medicines. Some of these, like acetaminophen, for example, and quetiapine, cough and cold medicines, some of these are not going to be fatal in just 1 or 2 tablets, but some of these will, the calcium channel blockers and the opioids, for example. With the cough and cold medicines, we've actually seen a decline in poisonings and also fatalities since the recommendations were made not to give these products to small children, and also some of those products being taken off the market. Many of the fatalities that were reported in the past with those medications were in children who were being misdosed by parents or caregivers. Now, a little bit of history for you. In the 1990s, iron poisoning was a common cause of death in children, but changes in the appearance and the packaging of iron supplements has really made a big difference in the incidence of fatalities. Here's a list of 1-pill killers. This is a list of medicines that maybe 1 tablet, 1 capsule, 1 teaspoonful could produce severe toxicity and even the possibility of death if a child ingested them. So these are the ones I'm going to go over in a little more detail. But first would be the opioids, also clonidine and guanfacine, topical imidazolines like Visine, for example, oral hypoglycemics, specifically the sulfonylureas, calcium channel blockers, camphor, and also methyl salicylate, which is also known as oil of wintergreen. So let's start with opioid overdoses. This is a 2-year-old child that drank some juice and then took a nap. The child was found cold, limp, and barely breathing and had no response to naloxone and had to be intubated. The urine toxicology was positive for methadone, and it was determined that the juice actually contained a take-home methadone dose for a family member. Unfortunately, this child died on the 7th day of admission to the hospital. Opioid analgesics include the drugs methadone, oxycodone, fentanyl, hydrocodone, hydromorphone, oxymorphone, buprenorphine, tramadol, tapentadol, and all of these opioid analgesics have various affinities for the mu, kappa, and delta opioid receptors. With many of these, as little as 1 tablet in a child could produce significant symptoms that could lead to death. The symptoms that you see with an opioid overdose in a child would be central nervous system depression. So they become very lethargic, maybe go into a coma. They can develop respiratory depression. Constricted pupils are often evident. They can also develop hypotension, bradycardia, and hypothermia. With methadone, we do have a chance of seeing QT prolongation in children as well as adults. And with some of the opioids like tramadol and meperidine, we can also see seizures. So this is what we consider the opioid toxidrome and what we look for in a patient that may have taken an opioid. To determine the toxic dose of one opioid versus another, we need to look at opioid equivalent doses. And at our poison center, we use a codeine equivalent to determine whether the child needs to go to the hospital or not. So 5 milligrams per kilogram of codeine has caused respiratory depression, and so we convert the other opioid analgesics to codeine, figure out the milligram per kilogram dose, and then determine whether the child needs to be sent in or not. So for example, 50 milligrams of methadone is equivalent to 500 milligrams of codeine equivalent. And for a 10 kilogram child, 500 milligrams of codeine divided by 10 kilograms, if that's what the child weighed, gives you a dose that the child took of 50 milligrams per kilogram. So that's 10 times what our threshold is for sending a child to the emergency department. So 1 methadone certainly would have the potential of causing a fatality in a child. The treatment for opioid overdoses involves supportive care, respiratory support specifically, activated charcoal if the ingestion has been soon, maybe within an hour or so after the ingestion. And then naloxone is the specific antidote that can reverse the central nervous system and respiratory depression. The dose in a small child is 0.1 to 2 milligrams, and that can be given IV, IM, or intranasally. If it's given intranasally by an atomizer, you need to give small amounts in the nostril. We usually recommend splitting the dose, giving half in one nostril and half in the other. It has a short duration of action, so for the longer opioids like methadone, you may need to put them on an naloxone infusion while they're hospitalized. Clonidine is another drug that's very toxic in small amounts. Clonidine is a selective alpha-2 adrenergic receptor agonist. It was originally developed as a nasal decongestant, but it's used for hypertension in adults. It's also used for ADHD in children. Its indications have been expanded to include narcotic and alcohol withdrawal. Since the late 1990s, most cases of clonidine overdoses in children have actually involved the clonidine that belongs to children, whether it's that child's medicine or maybe a sibling's medication. There have been numerous case reports in the literature of doses as low as 0.1 to 0.3 milligrams causing severe toxicity. So certainly that would be one tablet, could cause very severe symptoms in children. The clinical effects are seen usually within 1/2 to 4 hours. Initially, because there's some stimulation of peripheral alpha-2 receptors, you can get some transient hypertension and also tachycardia. And then when you get excessive stimulation of the presynaptic alpha-2 receptors in the lower brainstem, you get decreased plasma norepinephrine concentrations, and then you see hypotension and bradycardia, and that certainly is what we're concerned about in these small children. Also, CNS depression, so they're lethargic or in a coma. Respiratory depression and apnea can occur. They have constricted pupils. They can be hypothermic. So it actually looks very, very much like a opioid analgesic overdose. And naloxone has been shown to be effective, particularly in children. Not all cases, maybe 50% of cases or so, but certainly I would reach for the naloxone to try to reverse the central nervous system and respiratory depression in small children. There have also been case reports of children being exposed to unused or used and discarded clonidine patches. Often the patch goes unnoticed until symptoms develop and then the child's taken to the hospital. So here are two of the cases that have been reported. This is a 12-month-old that was found unarousable in a crib, had a heart rate of 72, a blood pressure of 80/40, respiratory rate of 22, and had meiosis or constricted pupils. And they found a transdermal clonidine 2.5 milligram patch that was stuck to the hard palate of the child. So the child had gotten the patch from some source and had put it in the mouth, and it stuck to the mouth. The second case was a 2-year-old with lethargy and gasping respirations with a heart rate of 75 and a blood pressure of 90/50, also had constricted pupils. And this child also had a discarded clonidine patch on her that was not detected until the child got to the emergency department. In both cases, once the patch was removed and the children were treated with supportive care and also, I believe, naloxone in at least one of the cases, then the children did fine. Guanfacine is an alpha-2 adrenergic receptor agonist, and it's used in the management of hypertension, either as a monotherapy agent or in combination with other antihypertensives, especially thiazide diuretics. The extended release formulation is also used for the treatment of attention deficit hyperactivity disorder as monotherapy and also as adjunctive therapy to other stimulant medications in kids and adolescents. And it's very structurally similar to clonidine. This is a case of a guanfacine overdose, a small amount that produced severe symptoms in a child. This is a 4-year-old that was taking 10x, so guanfacine, for 7 months for ADHD. He was switched to Intuniv 1 milligram for over 7 days and then increased to 2 milligrams. After 2 days, he had increased sleepiness, and his dose was withheld for 1 day, and then he was restarted on 1 milligram. 3 days later, he was again very sleepy. He was staring off when he wasn't falling asleep, and at that point he was taken to the emergency department. He had bradycardia, he had a heart rate of 50/56, and his blood pressure was initially high and then it dropped. A poison center was called at that point and recommended giving the child 0.1 milligram of naloxone. 4 minutes later, his heart rate increased to 100. He became much more alert. 40 minutes later, his heart rate fell to 61. He became lethargic again, and he was placed on a naloxone infusion for approximately 24 hours. Extensive questioning showed that there was no history of additional doses taken or other meds taken, so this was a pretty extreme response to a very low dose of guanfacine. Used primarily as topical agents to cause vasoconstriction in the nasal mucosa in the eye. There are a group of drugs called the Imidazoline Decongestants, and they include tetrahydrozoline, oxymetazoline, nefazoline, and xylometazoline. These are in products such as Afrin, Visine, Nafcon-A, Otrivin, and there are a lot of other eye drops and nose drops that might have these medications in them. There are many cases of pediatric ingestions reported to poison centers each year, and probably because the products are easily accessible to children, and many of them don't have child-resistant caps, and parents also might not think of these products as being harmful to children. The imidazoline decongestants have activity a lot like clonidine, the alpha-2 agonist activity, but they also stimulate peripheral alpha-2 receptors on local blood vessels to produce vasoconstriction. So the expected symptoms would actually be hypertension and tachycardia, agitation, cyanosis, diaphoresis, but in overdoses, you basically will see Clonidine-like signs and symptoms such as lethargy, bradycardia, and hypotension when ingested due to stimulation of the central alpha-2 receptors. You can also expect to see respiratory depression, apnea, and hypothermia. Now this is a case of an oral hypoglycemic overdose. This is a 2-year-old girl that ate one of her father's Glucotrol XL 10 milligram tablets. The pediatrician was called, and he recommended that the parents just observe for changes in behavior. 4 hours later, the child was noticed to be lethargic, and she was taken to the emergency department. She was limp. She was very lethargic on arrival. She didn't respond to painful stimuli, which included placement of an IV line. Her initial finger stick was 39 milligrams per deciliter. A bolus of 2 milliliters per kilogram of D50 was given along with food and juice. 1 hour later, she was lethargic again. She had a finger stick of 47 milligrams per deciliter. Another bolus of dextrose was given, and an IV of D5 half normal saline was started. And the following glucose measurements were all above 60 milligrams per deciliter. She was admitted for 2 days and then discharged home in good condition. Sulfonylureas include the older drugs, the first-generation drugs, chlorpropamide, talazimide, tolbutamide, and the second-generation drugs, glipizide, glyburide, and glimepiride. They stimulate insulin secretion from the beta cells of the pancreatic islet, and toxicity is primarily hypoglycemia due to the increase in insulin secretion and enhanced insulin action on target cells. The prolonged hypoglycemia can lead to depletion of glucose and glycogen stores. And amino acids and lipids then are utilized instead, and that can result in irreversible central nervous system damage even when glucose supplementation is given. There are many case reports of 1 or 2 tablets causing very severe hypoglycemia. The hypoglycemia can be prolonged, especially with some of the drugs like chlorpropamide and glyburide and the long-acting glipizide preparations. Hypoglycemia is defined as a glucose of less than 60 milligrams per deciliter. When the glucose drops below that level, you can see a wide range of effects. Some with lower glucose concentrations might not have any symptoms at all, but the lower it goes, the more likely the child will develop serious effects. Mild hypoglycemia will exhibit as tremor, sweating, tachycardia, nausea, and drowsiness. Symptoms of the early and the mild hypoglycemia in some cases might be quite difficult to recognize in a small child. Severe hypoglycemia will develop, and you'll see delirium, coma, seizures, and dysrhythmias, particularly sinus tachycardia, atrial fibrillation, and PVCs. Treatment of sulfonylurea overdose consists of, first of all, checking the glucose, the blood glucose, getting finger sticks about every 1 to 2 hours, and they need to be observed for a good 12 to 24 hours, especially the 24-hour period for glyburide or extended-release glipizide. They should have free access to food and drink. Encourage the kids to drink and eat food to try to keep their glucoses up. Also, activated charcoal can be given if the ingestion's been within an hour of the child coming into the emergency department. As far as glucose supplementation, dextrose 1 gram per kilogram should be given as a bolus if the child has symptoms or if the glucose is less than 60 milligrams per deciliter. Typically, if the child is at least 2 years of age, the dextrose is given in a dose of 1 to 2 milliliters per kilogram of D50 and 2 to 4 milliliters of D25 if the child's less than 2. And then that's usually followed by an infusion of dextrose. There is an antidote. It's called octreotide. It's a somatostatin analog, and it's a potent inhibitor of insulin release. When you give dextrose to these kids, the blood glucose goes up, and then that stimulates more insulin release, and so the blood glucose can then drop very low again. The more dextrose is given, the more insulin is released, and so you get these up and down, high and low glucose levels. So giving octreotide actually blocks the insulin from being released, and so the child will experience fewer hypoglycemic events and will need less dextrose. It's given sub-Q in a dose of 2 micrograms per kilogram, and that can be repeated every 6 to 12 hours as needed. We also will put them on a dextrose infusion, the concentration of which really depends on what the child's glucose levels are. There are very few adverse effects with octreotide, and so it's a very safe antidote to give in these cases. Calcium channel blockers can be extremely dangerous in small children with very small doses. This is a 2-year-old, 25-pound child that was found lethargic by her grandmother. There was an open bottle of the grandmother's heart medicine, which was Isoptin SR 180 milligrams, nearby, and there were scattered pills on the floor of her room. They counted the pills, and they could only count for maybe 1 or 2 tablets that were missing. The respiratory rate was 20 and shallow. The lungs were clear. The pulse was not detectable at all. Her blood pressure was 30 systolic, and she had grayish skin color. On the ECG, she had 3rd-degree AV block with intermittent P waves and a narrow QRS. She did fine. She needed a lot of drug therapy to reverse the effects. It was this child was at risk of dying, but fortunately this child recovered. There are several calcium channel blockers that are sold, and a lot of these are very widely prescribed. And I'm sure you see a lot of prescriptions for these, such as verapamil, diltiazem, nifedipine, amlodipine. And there are a lot of them. And the mechanism of action, just as a reminder, is that they bind to and they antagonize L-type calcium channels, and then that results in relaxation of smooth muscle. Vascular smooth muscle produces arterial vasodilation and decreased force of cardiac contraction, decreased heart rate, and conduction. The clinical effects that you see with overdoses include lethargy, slurred speech, confusion. You can also see seizures, coma, vomiting. But we're more concerned about the cardiovascular effects. And so we look for hypotension, bradycardia. And then with some of the drugs, particularly diltiazem and verapamil, you will see some conduction disturbances. So AV block, asystole can occur. One of the exceptions to the heart rate is with nifedipine and some of the dihydropyridines, you may get a reflex tachycardia instead of bradycardia. Also, hyperglycemia can be seen with calcium channel blockers. And then when the child is extremely ill, there is a chance also of ileus and bowel ischemia. Children need to be admitted for 12 to 24 hours without exception, even if they have no symptoms, because a lot of these drugs do have delayed effects, and many of them are in a sustained release form, so you will get a delayed onset. So certainly they need to be admitted to an intensive care unit, preferably for at least 12 to 24 hours. Supportive care is very important to provide. Activated charcoal can be given if it was a recent ingestion. And then for some of the sustained release products, we actually can resort to whole bowel irrigation. Whole bowel irrigation is giving an electrolyte solution such as Go Lightly, and that actually will push the drug through or eliminate the drug before the formulation can be absorbed out of the gastrointestinal tract. What we usually give is something like Go Lightly in a dose of about 500 milliliters per hour if the child is somewhere between 9 months to 6 years of age. IV fluids, vasopressors such as norepinephrine or epinephrine, and inotrope agents also can be administered for hypotension. Atropine is usually given for bradycardia. It's not always successful, but certainly we would try atropine for bradycardia. Calcium can reverse the myocardial suppression and also can improve the AV nodal conduction. It's more effective with mild toxicity in children than with children who are severely toxic. Glucagon is a drug that's also used in calcium channel blocker overdoses, mainly because it's very efficacious in treating beta blocker overdoses, but probably not as effective in calcium channel blocker overdoses. Glucagon can bind to the myocardium and increase cyclic AMP levels. That promotes calcium influx and produces a positive inotropic effect. Hyperinsulinemia, euglycemia, is another method of trying to reverse the cardiac effects, and basically what that is giving high doses of insulin to produce a positive inotropic effect and giving glucose along with that to reverse the hypoglycemia you're going to get from the insulin. And it's usually used if the hypotension hasn't responded to fluids or vasopressors, calcium, and glucagon. The dose that's given is usually about 1 unit per kilogram, although there have been cases where higher doses, maybe even as high as 10 units per kilogram, have been given with good results. Intravenous fat emulsion is basically intralipid, and it's given to trap lipid-soluble drugs like verapamil in the blood and keep it away from receptors and target organs. And it's basically a last resort therapy, a last resort attempt to reverse the cardiac effects. There are also some invasive treatments that can be used to support blood pressure and conduction. With small children, sometimes ECMO or extracorporeal membrane oxygenation, where the blood is oxygenated out of the body and returned to the body. That's something that's also done as a last resort. Camphor is a household product that we hear a lot of calls about as it relates to small children getting into these products. Camphor is available in topical products such as Campho-Phenique, that's used topically for cold sores, Vicks Vapor Rub, Vicks Vapor Steam, products like that, generic products, other brand names. And it's also used in other types of topical rubs in low concentrations. It can be found in mothballs. In the past it was found in mothballs, but now you rarely see it in mothballs, although we've had some reports recently of some mothballs being sold in some dollar stores where they've been imported and they have camphor in them. Also, camphorated oil. Camphorated oil is 20% camphor. It was removed from the market in 1982 because of unintentional ingestions and deaths in adults and as well as children, but it is still available in other countries. So although it's a very high percentage and extremely toxic, we don't hear about it that much anymore, but certainly it is possible that some homes might have that. Because of the toxicity in the case reports, the concentration or the limit of camphor was set at 11% in any of the consumer products that are sold in the United States. The American Academy of Pediatrics actually recommends that nobody have camphor products at all in the home where there's a small child, and to not use camphor at all in small children, stating that no one needs camphor. With doses as little as 10 milligrams per kilogram with camphor, you can see some nausea and vomiting. You see serious toxicity, usually around 30 milligrams per kilogram, and some sources will actually name just a dose of 500 milligrams as being a toxic dose in children. 1 gram has resulted in death in a small child. Now that equates to about 2 teaspoonsful of Campho-Phenique, about a tablespoonful of Vicks Vapor Steam, and about 2 teaspoonsful of Vicks Vapor Rub. So very small amounts can produce very serious toxicity and even death in small children. Camphor is very rapidly absorbed, and the onset of symptoms occurs usually within 5 minutes to an hour. Sometimes you'll see vomiting, nausea and vomiting first, but you can see more serious symptoms even without any of these minor symptoms showing up first. But you can see vomiting, confusion, they can be agitated, They can produce tachycardia, hyperreflexia, cyanosis. Seizures are what we're really worried about, and they can begin very, very abruptly. Treatment is supportive care. Activated charcoal could be given within an hour of the ingestion, keeping in mind that these products are very rapidly absorbed and you can see seizures before other symptoms and can occur as you're giving charcoal or soon after the charcoal is given, increasing the risk of aspiration. So you have to think twice sometimes before giving activated charcoal. Benzodiazepines certainly would be a drug that we would want to give for seizures, or even if the child is starting to become a little hyperreflexic or have tremors, indicating that maybe the child is developing symptoms and might have seizures. So benzodiazepines are the drug of choice. We recommend usually observing for at least 3 hours before discharging the patient. Methyl salicylate is used as a flavoring agent. It's also used in topical liniments such as Icy Hot and Bengay. It's a counter-irritant. It's also used in some Chinese patent medicines. Methyl salicylate is also known as oil of wintergreen, and oil of wintergreen can be purchased in bottles where it's 98% methyl salicylate. It's also very rapidly absorbed orally and very toxic. 1 teaspoonful of oil of wintergreen is the equivalent of a child ingesting about 7 grams of salicylate. So that equals approximately 22 adult-strength aspirin tablets. Most of the products have as much as 30% methyl salicylate in them, so certainly very small amounts could be toxic in children. 4 milliliters of oil of wintergreen has been lethal, so that's less than a teaspoonful, so certainly a mouthful or less could be lethal in a small child. Symptoms you see are nausea and vomiting, also central nervous system symptoms such as lethargy, confusion. They may have symptoms like you would expect with an aspirin overdose, such as ringing in the ears, hyperventilation, seizures, coma. They can become hyperthermic, and they can develop cerebral edema. They can also develop tachycardia, hypotension, and dysrhythmias, and they often get a lot of acid-base disturbances. Usually they start out with a respiratory alkalosis because of hyperventilation, and then they develop an anion gap metabolic acidosis. Now, methyl salicylate toxicity is not all that common because oil of wintergreen is not a very common product that you see. However, we do get a lot of calls about children ingesting the other products that contain fairly high concentrations. And our poison center recently, we were consulted on a case of a small child that ingested 1 teaspoonful of oil of wintergreen and became severely toxic. It had an extremely high salicylate level and certainly could have died if the child had not received good supportive care and other therapies. Treatment of methyl salicylate toxicity consists of supportive care. Also, activated charcoal could be used to try to bind some of the methyl salicylate in the GI tract if it's given early on. We recommend getting salicylate levels every 2 hours until the salicylate level peaks and starts coming down. And then you could get a little less often. We also recommend getting blood gases, arterial blood gases, and other routine labs. IV should be started, and the child who's symptomatic or has an elevated salicylate level should be started on sodium bicarbonate in the IV, and that produces what we call ion trapping. Salicylates are weak acids, and so by alkalinizing their urine, for one thing, it can increase the renal clearance of the drug, but by increasing the pH of the blood, you can increase the amount of salicylate in the blood and basically pull it out of the brain. So that helps to limit some of the central nervous system toxicity. Hemodialysis is performed if the child has very severe symptoms unresponsive to standard therapy, or if they have a salicylate level in an acute ingestion of greater than about 90 to 100 milligrams per deciliter. It's important, if you are involved with these patients, to realize that children should not be intubated and ventilated unless absolutely necessary. They're unable to maintain their minute volume that they need to compensate for the metabolic acidosis. So if they're intubated and ventilated at a lower respiratory rate, then often they do poorly. Here's a list of some other low-dose, high-risk pharmaceutical products that you should be aware of. Bupropion is one where you can see tachycardia, QTc prolongation, and especially seizures with small amounts, as little as 1 or 2 tablets of bupropion. Chloroquine and hydroxychloroquine are not as common as many of these other medications as far as keeping them around the house, but usage has increased as the indications for them has extended from malaria to things like lupus and rheumatoid arthritis and other similar indications. Children who ingest as little as 1 tablet can develop a rapid onset of symptoms with cardiac and neurologic symptoms predominating. So within 30 minutes to 3 hours, they can progress from hypotension and conduction delays and shortness of breath and drowsiness to low potassium levels, apnea, seizures, and death. Diphenoxylate and atropine, also known under the well-known brand name of Lamodal, is used for diarrhea. The diphenoxylate is an opioid, atropine is an anticholinergic agent. Toxic effects are delayed, and they usually present as opioid toxicity as well as anticholinergic toxicity. The tricyclic antidepressants, there are some severe case reports of 1 to 2 pills killing small children. There are a wide range of dosages available, and so it really depends on what strength the tablets are to fit them into this 1 pill killer list. For amitriptyline, the toxic dose is usually about 5 milligrams per kilogram, but deaths have been seen with 15 milligrams per kilogram. Most fatalities with these drugs have been with doses higher than 30 milligrams per kilogram. But what you'll see is dysrhythmias, usually tachycardia and a wide QRS interval, and also hypotension. A few of the newer atypical antipsychotic agents can also be very toxic in small amounts in children. Olanzapine, aripiprazole, and clozapine have been known to produce very significant CNS depression that requires airway protection in children that have ingested as little as 1 tablet. Also, extrapyramidal symptoms are possible. Fortunately, most children will recover with good supportive care. With the 1A antidysrhythmic agents like quinidine, procainamide, as little as 1 or 2 tablets has caused some severe toxicity. And small children are especially prone to toxicity because they have less protein binding, and so more of the drug is in the free form and available to produce symptoms. Cardiovascular effects are likely to occur, and that's primarily due to potassium and sodium channel blockade. So you'll see maybe a wide QRS and QTc interval, as well as other dysrhythmias. Also, visual disturbances, seizure, and shock can occur. We also hear a lot of ingestions with topical anesthetic agents like benzocaine and lidocaine in teething gels or maybe a viscous lidocaine product. Also, there have been numerous severely toxic reports with overuse of topical local anesthetic agents, so applying it to the child, especially with maybe something like EMLA cream. Children have developed things like confusion, agitation, seizures, tachycardia, QRS prolongation, and hypotension. So let's go over some ways of preventing poisonings. And these are tips or information that you can pass along to your patients to try to prevent poisonings from occurring in general in pediatric patients, and specifically with these more toxic drugs. First, you should raise awareness of these 1-pill killers when dispensing these prescriptions. If you dispense something, maybe a calcium channel blocker like verapamil, to someone that you know has a small child or a grandparent, please make them aware that these medicines are extremely dangerous if children ingest very small numbers of them. Keep medicines up and away and out of sight, even when it's more convenient to leave it out on a bedside table or a kitchen counter. Remember that in 67% of the emergency department visits for medicine exposures, the drug was left within sight and reach of the child. So lock them up. That's the best advice, since children can climb to high places. It's important to keep bags and purses and coats away from children, and put medicines away in between doses. Use alarms, use notes, remind your patients to use things like that instead of leaving the medicine in a convenient area to be used as a reminder to take it. Medicines should be kept in their original containers with labels on them so that we know what the products are, what the drugs are. But if patients need to use something like a daily pill container, it's important to keep them out of the reach of children and locked up because they're not in child-resistant containers. Now, while we're on the subject of child-resistant containers, let's talk a little bit about those. The Poison Prevention Packaging Act was passed in 1970 and took effect in 1972, at first with aspirin bottles, and poisonings decreased soon after. The Poison Prevention Packaging Act requires child protective packaging in substances that include medicines and also some solvents and oils. Because of children aspirating the oils and causing fatalities. So oils like lamp oil. Within the first few years of instituting the child-resistant containers, there was a study that was published in 1979 and showed a 50% decrease in baby aspirin poisonings and a 42% decrease with adult-strength aspirin poisonings just within those first few years. Pediatric fatalities reported to poison centers decreased from more than 200 a year to approximately 20 to 35 per year after these products, these drugs, prescriptions being dispensed, included child-resistant caps. There are many studies, though, out there that show that there have been a decline in poisonings and deaths after this act was instituted compared to before. One study more recently done in 1996 showed that a substantial number of poisonings, as high as 40%, were due to either improperly secured caps or products that weren't required to be packaged in child-resistant containers. So it just shows that if you use them properly, then there's a real good chance that a child's not going to get into them. But they're not child-proof. Adults have to be able to open them also, so they can't be completely child-proof. So they're used as a last resort prevention strategy. The products still need to be kept away from children and locked up. So encourage your patients to use child-resistant containers. And if they have small children or if it's a grandparent that takes care of small children, don't encourage them to decline using the child-resistant containers when they get their prescription. Unfortunately, many people who are older and with arthritis have trouble opening them, and so they do decline using them, but they need to be aware of the fact that these medicines can be very toxic. Children should be taught to never touch or put anything in their mouths unless they ask an adult. And also, your public need to be aware of lookalikes. There are a lot of products out there that resemble candy or food products. Children can't read labels, and so it's very important to keep these products away from children so they don't think that it's something easy to eat or drink. And products also should never be stored in food containers. That also will confuse children, and they're likely to pick up the container and drink from it. Encourage your patients to never take medicine in front of children, never call medicine candy, to get rid of old or expired medicines, and also to read and follow directions on all medicines. Use the dosing device that comes with the product, if there is one, and measure carefully, because a lot of overdoses and even some fatalities have been from misdosing the child with the medication. Don't give children adult medicines when there are children's medicines available. Read the label and make sure it is intended to be given to a child. Also, labels should be read to make sure that parents are not giving their children multiple products that contain the same medication. And lastly, make sure that your patients do have the Poison Center phone number available to them. So if they do suspect that a child ingests something like one of these medications or any product, that they should call the Poison Center right away. The Poison Center number is 1-800-222-1222.